Okay, let's set a scene. Imagine a 15-year-old boy. He walks into an emergency clinic, and you can tell right away something is seriously wrong.
He's not walking normally?
No, not at all. He's hunched over, kind of clutching his stomach, and every single step looks like it's sending a jolt of pain through his whole body.
It's a classic picture, one that plays out in emergency departments. Well, everywhere, every single day.
He gets to the triage nurse and says he has this pain in his belly, specifically the lower front part.
And if you know the code, if you know what you're looking for, his body is practically shouting the diagnosis at you.
Exactly. So they get him in, take his vitals. He's got a fever. It's 101 degrees Fahrenheit, which is about 38.3 Celsius. He looks flushed.
And then the doctor does something a little old school, something you see in all the textbooks.
Asks him to stick out his tongue.
And this detail is so important. His tongue is coated. It's got this thick white film on it.
The texts call it a furred tongue, which is just, it's a very visceral image.
It is. It's a sign that the whole system is under stress. He's inflamed. He's probably dehydrated. But the real story, the critical clue, is happening a few feet lower.
The physical exam. So the doctor goes to examine his abdomen, puts a hand on the lower right quadrant.
And the reaction is immediate.
It's not just that he flinches or says, ouch. The muscles underneath the doctor's hand are, well, they're hard. Like a plank of wood, they're rigid.
That is the single most important physical finding, that rigidity.
And when the doctor presses down, even gently, those muscles spasm even more. The chart notes call it guarding.
Right. And in that one moment, for most experienced clinicians, the diagnosis is already 90% made.
Acute appendicitis.
Acute appendicitis. But for our deep dive today, we're not just going to name the disease and move on. We want to understand the mechanics of it. Why that rigidity? Why did his body build this muscular shield?
And why did the pain probably start somewhere else, like around his belly button, before it moved to that specific spot?
Exactly. Yeah. Because to someone who hasn't studied it, the abdomen is it's a black box. You have pain, you don't know why. But once you understand the map inside, that box becomes transparent.
And that rigidity, it wasn't a symptom of the appendix itself, was it? I mean, the appendix doesn't have muscles that can do that.
No, absolutely not. That's a common misconception. It wasn't the organ. It was a reflex. It was a protective mechanism triggered by something called the parietal peritoneum.
Okay, so that distinction is key, the organ versus the wall.
It is the key that unlocks almost all abdominal pain.
So today, we are diving deep. We are cracking open one of the foundational texts, Snell's Clinical Anatomy, and we're focusing on the chapter called Abdomen Part 2, the abdominal cavity.
And I want to set the stage for everyone listening right now. We're not going to just read you a list of organs and nerves. That's not what this is about. We are building a mental model.
Right. Anatomy is so often taught as just pure memorization. Label this, label that, pass the exam, and then, promptly forget it.
But clinical anatomy, the way Snell approaches it, is about function. It's about understanding the abdomen as a three-dimensional space where gravity matters, where pressure matters, where the wiring diagram dictates everything.
Our goal here is to be the primer. We want this deep dive to make you actually want to go find a copy of Snell's and open it up. We can describe the landscape, but you really need to see the diagrams, the maps, to make it stick.
Exactly. Think of this as the why behind the what.
Sure.
Reading these big, comprehensive texts is unfortunately becoming a bit of a lost art. We all want the quick summary, the app, the flashcard.
Sure.
But if you can build this 3D model in your mind by wrestling with the text and its diagrams, you stop memorizing lists of symptoms and you start predicting them. You become a diagnostician.
Okay, so let's start building that model. Let's go back to our 15-year-old boy and his stomach that felt like a board. To get why that happened, we have to start with the absolute basics. Section 1, the balloon and the wall.
This is it. This is the concept that trips up so many students, and honestly, a lot of doctors in training too. The abdominal cavity is lined by this continuous membrane called the peritoneum.
And you have to visualize it in a very specific way for it to make any sense.
The analogy in the book is perfect. I want everyone listening to try and picture this. Imagine a room. The walls of that room are your abdominal muscles, your back, your diaphragm.
Okay, I'm in a room.
Now, inside that room, imagine a giant, completely deflated balloon. It's just a limp bag of rubber in the middle of the floor.
Got it.
Now, take your fist. Your fist is going to represent an organ, let's say a loop of small intestine. And from outside the balloon, push your fist deep into it.
Okay, so I'm punching the balloon but not breaking it. The balloon is now wrapping around my fist.
Exactly. The layer of the balloon that is stretched tight against your fist, the rubber that's touching your skin, That is the visceral peritoneum.
Visceral means organ.
Visceral means organ. It's like the skin of the organ itself. It's paper thin, and it's stuck right on there.
Okay, so visceral equals organ skin. What about the rest of the balloon? The part that's not touching my fist, but is now pushed up against the walls of the room.
That is the parietal peritoneum. Think parietal like perimeter. It's the wallpaper of your abdominal cavity. It's lining your abdominal muscles, the underside of your diaphragm, the inside of your pelvis.
And the space inside the balloon? Between the layer on my fist and the layer on the wall.
That's the peritoneal cavity. But, and this is crucial, remember the balloon is deflated. It's a potential space. In a healthy person, there's no air in there. There is just a tiny film of serous fluid.
What does that do?
It's lubricant. It's secreted by the peritoneum itself, and it allows all those organs, your intestines, your stomach, to slide past each other and past the abdominal wall without any friction.
It's like a perfectly lubricated bearing system.
A perfect biological bearing. It allows for movement, for digestion, for everything to happen smoothly.
Okay, now this is where it connects back to our teenager and his pain. Because these two layers, the visceral on the organ and the parietal on a wall, they're not wired the same way at all.
Not even close. It's like they're connected to two completely different electrical grids.
So let's start with the visceral layer, the one on the organ.
The visceral peritoneum is supplied by the autonomic nervous system.
Yeah.
This is the same system that handles your heart rate, your breathing, your digestion. It's your body's automatic unconscious control system.
And the autonomic system is, well, it's not very good with maps, is it?
It's terrible at geography. It's evolved to sense internal states, not pinpoint external threats. It can tell you if an organ is being stretched, or if it's ischemic, not getting enough blood, or if it's distended with gas.
But it can't tell you where it's happening.
Not with any precision. When you irritate the visceral peritoneum, the brain just registers this dull, deep, aching pain. It's poorly localized.
So it's just a general alarm bell. Something is wrong down there.
Exactly. And characteristically, that pain is referred to the midline of the body. If the problem is in the foregut stomach, liver, you feel it in the epigastrium at the pit of your stomach. If it's the midgut, which includes the appendix,
You feel it around the belly button, the umbilicus.
you feel it around the belly button.
Yeah.
So when that boy's appendix first got inflamed, it started to swell. That swelling stretched the visceral peritoneum wrapped around it.
And his first symptom was probably a vague stomach ache right in the middle.
He couldn't point to it with one finger. He would have waved his hand over his entire central abdomen and just said, I don't feel good.
But by the time he got to the clinic, he was pointing right to the lower right corner. What happened? What changed?
The disease progressed. The inflammation got worse and worse, so bad that it burned through the wall of the appendix through that visceral layer, and it started to irritate the other layer.
The wallpaper, the parietal peritoneum.
And the parietal peritoneum is a completely different story. It is supplied by somatic nerves.
The same kind of nerves that are in our skin and our muscles. The ones that let us feel a pinprick.
Precisely. These are high-definition, GPS-enabled nerves. They can map the body down to the millimeter. So when that inflammation touched the parietal peritoneum on the inside of his abdominal wall, the brain knew exactly where the fire was.
It said, problem located, lower right quadrant, sharp pain, right here.
The migration of pain from the umbilicus to the lower right quadrant is the story of the inflammation moving from the organ to the wall. It's a shift from the autonomic system to the somatic system.
And the rigidity, the guarding, where does that come in?
That's a somatic reflex. The same segmental nerves that supply that patch of parietal peritoneum also supply the abdominal muscles sitting directly on top of it.
So they're on the same circuit.
They're on the same circuit breaker. When the peritoneum screams in pain, the signal goes to the spinal cord, and an immediate involuntary reflex arc fires right back to those muscles and says, lockdown, do not move.
It's creating a biological splint.
It is trying to immobilize that part of the abdominal wall because any movement, breathing, coughing, walking is going to jiggle that inflamed tissue and cause excruciating pain. That guarding is involuntary. The kid can't relax those muscles even if you ask him to.
That is just, it's a fascinating and intelligent biological defense mechanism.
It is. But not everything in the abdomen lives inside that balloon. To really understand the different ways things can go wrong, we have to talk about the organs that hide out back.
The retroperitoneal space. Okay, this is a term that gets thrown around constantly, but I think a lot of people, myself included sometimes, don't have a great 3D picture of what it really means.
And not having that picture can lead you to miss some very serious diagnoses.
So we established that intraperitoneal means an organ is basically wrapped in the balloon and is mobile, like the stomach or the spleen.
Right, it's hanging on a stalk of peritoneum called a mesentery, and it can move around.
So what does retroperitoneal actually look like?
Go back to our room with the balloon. Now imagine you've pushed that balloon all the way up against the back wall of the room. The organs that are trapped behind the balloon, sandwiched between the parietal peritoneum and the deep muscles of the back, those are retroperitoneal.
So the balloon is only covering their front surface.
Correct. For all intents and purposes, they are plastered to the posterior abdominal wall. They are fixed in place. They don't float around like the intestines do.
And of course, there's a mnemonic for this. It's a classic for a reason. Anchors like this are just so important when you're learning this stuff.
They really are. The most common one is sad pucker.
I love this one. Okay, let's walk through it because the position of each of these organs has a really important clinical meaning. SADPUCKER.
Let's do it. S is for the suprarenal glands. Those are the adrenal glands which sit like little hats on top of the kidneys.
Okay.
A is for the aorta and the inferior vena cava, the two biggest blood vessels in your body running right up against the spine. D is for the duodenum, but specifically the second, third, and fourth parts of it. The very beginning of the small intestine is actually fixed to the back wall.
Okay, that's SAD. Now for pucker.
P is for the pancreas.
Yeah.
This is a huge one. The pancreas is notoriously difficult to examine because it's so deep, tucked away behind the stomach.
U.
U is for the ureters, the little tubes that carry urine from the kidneys down to the bladder.
C.
C is for the colon, but only the sides of the frame. The ascending and descending colon are fixed retroperitoneally. The transverse part in the middle is not.
Okay. KER.
K is for kidneys, the biggest retroperitoneal organs. E is for the esophagus, just at the very tail end of it as it enters the abdomen. And R is for the rectum.
So why does this matter so much? Other than for a surgeon trying to get to one of these things, how does it change how a patient presents?
It changes everything about the pain. Let's take the pancreas again. If a patient has pancreatitis, a severe inflammation of the pancreas, where do they often say the pain is?
It's in their back, isn't it? They say it feels like a boring pain going straight through them.
Exactly. It's not a superficial bellyache like with the appendix. Because the inflamed pancreas is sitting right on the nerves and muscles of the posterior wall, the pain is felt deep in the back.
And Snell's brings up a really critical trauma scenario related to the aorta.
This is a life or death distinction. An abdominal aortic aneurysm that starts to leak. The aorta is retroperitoneal. If it had a massive rupture, it would be catastrophic no matter what.
But sometimes they leak slowly.
Yes, and because it's in that tight, fibrous retroperitoneal space, the initial bleeding can be contained.
So the pressure from the surrounding tissue kind of packs the wound.
It creates a tamponade effect.
Yeah.
It can form a hematoma that's held under pressure, buying the patient precious minutes or even hours to get to an operating room. If the aorta were intraperitoneal, floating freely, a leak would mean bleeding out into the entire abdominal cavity in minutes. That retroperitoneal location can be the difference between life and death.
Okay, I think this is a good spot for a quick check-in for everyone listening. We've thrown a lot of 3D geometry around.
Let's test it.
I want you to pause and really visualize that balloon in the room one more time. If you were to take a needle, and please, this is purely a thought experiment, do not do this, but if you were to poke your own belly button, which layer of peritoneum does that needle hit first? The visceral or the parietal?
Take a second. Think about the wallpaper versus the organ skin.
The answer is the parietal peritoneum. It's the wallpaper. It lines the inside of the anterior abdominal wall. You have to go through the wall to get into the room.
If you got that, you've nailed the most important concept so far. If not, just rewind 30 seconds and listen to the balloon analogy again. It's fundamental.
All right, moving on to section 2. We talked about the muscles on the outside creating a splint to contain infection. But there's actually an organ on the inside whose whole job is to be a first responder.
The abdominal policeman.
I just love that that's the actual term used in textbooks. It sounds like something out of a children's book about anatomy. We're talking about the greater omentum.
Yes. And if you're in a gross anatomy lab and you open up the abdomen, the greater omentum can be a little underwhelming. It just looks like this big, yellow, fatty curtain or apron hanging down from the bottom edge of the stomach.
It covers the intestines. It looks like a layer of insulation.
And it does act as insulation. It's rich in fat. But in a living person, It is anything but a static sheet of fat. This is the crucial part. It moves.
How does it move? It doesn't have muscles, right?
Not in the way we think of muscles, no.
Yeah.
It's moved around passively
Yeah.
by the peristalsis of the intestines writhing underneath it. But it also seems to have this chemotactic ability. It is drawn to sites of inflammation.
Drawn to them, you mean it migrates?
It physically moves and wraps itself around an inflamed area. If you have a hot appendix or a gallbladder that's about to rupture, or a perforated ulcer in your stomach, the omentum will find it.
And what does it do when it gets there?
It adheres to it. It sticks to the inflamed organ like glue and tries to seal off the leak. It walls off the infection.
So it's trying to stop a localized problem from becoming a systemic one.
It's trying to prevent generalized peritonitis. It's putting the offender in jail. When a surgeon goes in and sees the omentum balled up and stuck in one corner of the abdomen, they know the policeman has made an arrest. And the problem is right underneath.
That is just an incredible internal defense system.
It is. But sometimes the policeman fails, or the infection is too overwhelming. And when pus or fluid leaks out into the general cavity, where it goes is a matter of life and death.
Which brings us to what you call clinical fluid dynamics.
This is pure physics. It's gravity plus topography. The inside of the abdomen isn't a smooth bowl. The spine creates a big ridge down the middle, and that forms two big channels on either side.
The pericolic gutters.
Exactly. They run alongside the ascending and descending colon. You can think of them as storm drains. Any free fluid in the abdomen is going to flow along these gutters.
And where do they lead?
They lead up to the highest point, which is under the diaphragm, into the subphrenic spaces, and they lead down to the lowest point, which is the pelvis.
And you called the subphrenic space the danger zone? Why?
Because the peritoneum that lines the underside of the diaphragm is unique. It is riddled with huge lymphatic channels called stomata. It's designed like a superabsorbent sponge to suck up peritoneal fluid and keep the cavity dry.
Which is normally a good thing.
A very good thing. But if that fluid is pus, if it's full of bacteria and toxins from a ruptured intestine, that rapid absorption becomes your worst enemy.
You're mainlining the poison straight into your bloodstream.
You are. You get septicemia, you get shock very, very quickly. An abscess under the diaphragm is a surgical emergency of the highest order.
But the pelvis is different.
The pelvis is the opposite. The peritoneum down there is a very poor absorber. It's a much safer place for infected fluid to collect. It's like a sump pit in a basement.
And this knowledge directly changes patient care. It's not just a fun fact.
It is nursing 101 for anyone with an abdominal problem.
Yeah.
If you have a patient with peritonitis, a burst appendix, a perforated ulcer, you never ever let them lie flat on their back.
Because if they're supine, the fluid will run uphill.
It will flow straight up the pericolic gutters and pool right under the diaphragm in that high absorption danger zone. You are essentially helping the patient poison themselves.
So you sit them up.
You set them up, Fowler's position, prop them up on pillows at a 35-degree angle, let gravity become your friend. Let it drain all that pus and dirty fluid down the gutters and into the relative safety of the pelvic sump.
You sacrifice the pelvis to save the patient.
You can deal with a pelvic abscess.
Mhm.
It's contained, it's slow growing, it gives you time for antibiotics to work. You can drain it. A subphrenic abscess can kill a patient in hours.
That is such a clear, tangible application of anatomy. It's not just about naming the gutters, it's about using them. It's fluid engineering.
The body is a physical system. You have to respect the physics.
Okay, another quick check-in for section 2. Let's make this practical. If a loved one has just had abdominal surgery and the nurse keeps telling you to keep the head of their bed elevated, why are they doing that?
Don't just say for comfort. Think about the flow. Think about the gutters.
The answer you should be thinking is to use gravity to drain any potential fluid leak away from the rapid absorption zone under the diaphragm and down into the slow absorption sump of the pelvis.
Perfect. You've got it.
All right, let's move on to section 3. We've used it as our prime example, but now let's focus on the main culprit itself, the chameleon of the abdomen, the appendix.
The vermiform appendix, which is a great name. Vermiform just means worm-shaped, and that's what it is. A little narrow muscular tube that's packed with lymphoid tissue. It dangles off the posteromedial surface of the cecum.
The cecum being the very beginning of the large intestine.
Correct. And we all learned in school about McBurney's point, that landmark on the lower right side of the abdomen where you're supposed to find it.
And that's generally true, right?
It's true for the base of the appendix. Where it connects to the cecum, that part is pretty constant in its location.
But the tip of the appendix, that's a whole other ballgame.
The tip is a free agent. It can point in any direction. I tell students to think of the appendix like the hand on a clock. The center of the clock, the base, is fixed, but the hand can swing around 360 degrees and point up, down, left, right, or anywhere in between.
And Snell calls this variability the clinical trap.
Because it catches clinicians all the time. The location of the patient's pain depends entirely on where the inflamed tip of that appendix is pointing.
Okay, so let's walk through the most common variations. What's number one?
By far the most common position is retrosical. This means the appendix is tucked up behind the cecum, hiding behind the large intestine.
All right, so let's invent a patient to make this real. Let's call her Mrs. G. She's, say, 65 years old, comes in feeling vaguely unwell, nauseous, low-grade fever. The junior doctor goes to examine her, presses right on McBurney's point, and she barely flinches. She says, no, that doesn't really hurt.
And that junior doctor, if they're not thinking, might write in the chart. Abdomen soft, non-tender, appendicitis unlikely, and they might send her home.
Which could be a fatal mistake.
A disastrous mistake. Why didn't it hurt when he pressed on her belly?
Because he wasn't actually pressing on the appendix.
He wasn't. The cecum is a big bag of gas and stool. If the inflamed appendix is hiding behind it, pushing on the front just squishes the cushion of gas, you're not getting anywhere near the site of inflammation.
So that classic sign we saw in the teenage boy, the rigidity and guarding of the anterior abdominal wall, could be completely absent in Mrs. G.
Completely absent. So you have to be a detective. You have to look for other clues. You have to look for the psoas sign.
The psoas major is that huge muscle that runs from your lumbar spine down to your hip. It's a powerful hip flexor.
Right. And a retrocecal appendix lies directly on top of the right psoas muscle. If the appendix is inflamed, the muscle gets irritated. So Mrs. G might come in with a limp. Or you might notice she's lying on the gurney with her right hip and knee bent.
She's flexing her hip to keep the muscle relaxed and stop the pain.
She's unconsciously putting the muscle on slack. So the test isn't to push on her belly again. The test is to gently take her right leg and extend the hip, pull it backwards.
You're stretching the irritated muscle over the inflamed appendix.
And that will cause a sharp, deep pain. If the belly is soft, but the psoas stretch hurts, you have to assume it's a retrocecal appendicitis until proven otherwise.
Okay, what's another tricky position?
The pelvic position. The appendix, instead of pointing up, hangs straight down over the brim of the pelvis into the pelvic cavity.
So, again, pushing on the lower right quadrant of the abdomen might not do anything.
The inflammation is inches away from your hand. It's way down deep in the bowl of the pelvis.
So what symptoms would that patient have?
It could be anything. If the tip is irritating the rectum, they might have diarrhea. If it's irritating the bladder, they might have urinary frequency and think they have a UTI. The clues are very nonspecific.
So how on earth do you find it on physical exam?
This is why we still teach exams that students might find uncomfortable, but are absolutely necessary. You have to feel the pelvic peritoneum from the inside.
You're talking about a rectal or a vaginal exam.
You are. Because with your examining finger, you are now only separated from that inflamed appendix tip by the thin wall of the rectum or vagina. You might find no tenderness at all on the outside, but exquisite, localized tenderness on the right side of the rectal wall on the inside.
So the big takeaway is, appendicitis doesn't always live at McBurney's point.
The base lives there. The pain lives where the tip is. If the systemic signs are there, the fever, the nausea, the high white blood cell count, you have to hunt for it. Check the hip, check the pelvis. Never ever trust a soft belly by itself.
This all begs a really fundamental question, which brings us to section 4. Why? Why is the appendix in the lower right to begin with? Why is the colon shaped like a frame? This gets into the embryological spin.
This is one of the most incredible, almost unbelievable parts of our own development. When you were a tiny embryo, just a few weeks old, your gut started as a simple, straight tube. But it grew incredibly fast.
It outgrew the house.
It literally ran out of room. The liver and kidneys were also growing at a massive rate and taking up all the real estate in the abdominal cavity.
Yeah.
So to continue growing, the gut tube did something amazing. It herniated.
It moved out.
It pushed its way out of the body and into the umbilical cord. For a period of our fetal development, our intestines are actually outside our body.
That's wild. So we all have this period of physiological herniation.
We do. But the real magic isn't that it leaves. It's how it comes back in.
It doesn't just, reverse course and slide back in neatly.
Not at all. As it returns to the now larger abdominal cavity, it performs a complex rotation. It twists 270 degrees counterclockwise around the axis of its main blood supply, the superior mesenteric artery.
Okay, 270-degree counterclockwise spin. That's very specific.
It is incredibly precise. And that spin is what arranges the gut in its final adult configuration. It's what swings the cecum and appendix from the left side all the way over to the lower right. It's what drapes the transverse colon across the top. It creates that picture frame of the large intestine with the small intestine coiled up inside.
But I'm guessing that spin doesn't always go perfectly.
It doesn't. You can have malrotation. The rotation might stop halfway at 90 or 180 degrees, or it might rotate clockwise instead of counterclockwise.
So what would that mean for our patient with appendicitis?
It could mean their appendix isn't in the lower right at all. If the rotation stops early, the cecum might be stuck up high, right under the liver. So their appendicitis would present as upper right quadrant pain, mimicking gallbladder disease.
Or it could be on the left?
Or it could be on the left, which would confuse everyone. But there's an even more extreme version.
Situs inversus.
The complete mirror image. This is a rare congenital condition where everything is flipped. The liver is on the left, the spleen is on the right, the stomach points the other way.
And the appendix is in the lower left quadrant.
It is. So a patient comes in with all the classic signs and symptoms of appendicitis. The fever, the guarding, the migrating pain. But it's all happening on the left side of their body.
What does a good clinician do?
Before they anchor on a diagnosis of, say, diverticulitis, which is common on the left, they should do one simple thing. Put a stethoscope on the patient's chest.
To find the heartbeat.
To find the point of maximal impulse of the heart. If it's on the right side of the chest instead of the left, a condition called dextrocardia, you know you're dealing with situs inversus. And that left-sided appendicitis is, for that patient's anatomy, perfectly normal.
You have to confirm the map before you can read it.
You have to. You can't assume everybody follows the textbook. You have to treat the patient that's in front of you.
All right, let's stick with the map and talk about the highways that run through it. Section 5, vascular highways and pain maps.
The blood supply is everything. The abdomen gets its arterial blood from three main trunks off the aorta, the celiac trunk for the foregut, the superior mesenteric artery for the midgut, and the inferior mesenteric for the hindgut.
Those are the roads bringing supplies in. But I think the really fascinating clinical stories come from the drainage system, the venous side, because the plumbing here has a very specific detour that can cause some dramatic problems.
The portal system. This is a concept you have to understand. Blood returning from your legs or arms goes straight back to the heart through the big veins, the vena cava. But blood from your gut is different.
It doesn't go straight home.
Think about what's in that blood. It's full of all the nutrients you just absorbed from your lunch, which is good. But it could also be full of bacteria, toxins, medications, alcohol. You do not want that unfiltered slurry going directly to your brain, lungs, and heart.
So it has to go through a treatment plant first.
The liver. The portal vein collects all the venous blood from the intestines, the spleen, the stomach, and delivers it to the liver first. The liver then filters, detoxifies, and metabolizes everything before releasing the clean blood into the general circulation via the hepatic veins and the IVC.
Okay, but what happens when that treatment plant gets clogged? Like in a patient with severe liver disease, cirrhosis.
The liver becomes scarred and hard. Blood can't flow through it easily. It's like a massive traffic jam on the M25. The pressure in the pipeline leading to the liver, the portal vein, starts to skyrocket.
That's portal hypertension.
It is. And just like water in a blocked pipe, that high-pressure blood is going to try and find an escape route, a bypass.
It looks for back roads.
Exactly. It finds tiny, normally insignificant connections between the portal venous system and the main systemic venous system. We call these portosystemic anastomoses. Under high pressure, these little back roads are forced open and they swell up dramatically.
And this isn't just an internal problem. You can actually see the signs on the patient. Snell's mentions a really striking one around the belly button.
Caput medusae.
The head of Medusa.
The perumbilical veins are tiny veins around the navel that connect the portal system to the veins of the abdominal wall. When portal pressure is high, they engorge with backed up blood and become visible under the skin as large, radiating, snake-like veins.
It's a physical sign of severe internal liver failure written right there on the skin.
And it's a warning sign for an even more dangerous bypass, the one in the esophagus, esophageal varices. The veins at the bottom of the esophagus swell up like fragile balloons. If one of those bursts,
it's a massive life-threatening bleed.
a torrent. A patient can bleed to death very, very quickly. That's why seeing caput medusae is so ominous. If you see the snakes on the belly, you have to be terrified about the balloons in the throat.
Okay, let's pivot from blocked highways to crossed wires. Referred pain. We touched on it with the appendix pain starting in the middle, but the mechanism is just so interesting. Why does the brain make these mistakes?
The most accepted theory is about convergence. The sensory nerve fibers from an internal organ, say the gallbladder, enter the spinal cord at the very same level as the sensory nerve fibers from a patch of skin, say the shoulder.
So all the signals are coming into the same switchboard operator.
Right. And the brain is constantly getting signals from the skin touch, temperature, pressure. It's very familiar with that map.
Right.
It almost never gets pain signals from the gallbladder.
So when a strong pain signal comes in on that shared pathway, the brain just defaults to what it knows best.
It misinterprets the source. It assumes the signal must be coming from the skin, from the dermatome that shares that spinal level. The classic example Snell uses is the gallbladder.
The gallbladder is tucked under the liver in the upper right.
But when it gets inflamed, it irritates the diaphragm, which sits right on top of it. And the diaphragm's nerve supply is the physic nerve.
And I remember the rhyme from anatomy class. C3, 4, 5 keeps the diaphragm alive.
C3, 4, and 5. The phrenic nerve originates high up in the neck. But here's the key. The supraclavicular nerves, which provide sensation to the skin over the tip of your shoulder, also come from spinal roots C3 and C4.
So the pain signal travels from the diaphragm up the phrenic nerve to the C3, C4 level in the neck. The brain sees this burst of activity at C3, C4 and concludes...
My shoulder hurts.
Oh, wow. So a patient can come in complaining of severe right shoulder tip pain. You examine the shoulder. It's not red. It's not swollen. They have full range of motion, but they are in agony. And the problem is actually gallstones.
And if you don't know that referred pain map, you might send them home with some painkillers for a strained muscle, and their gallbladder could rupture a day later.
It's a coded message. You have to know the key.
And the key, almost always, is embryology. The nerve supply follows the organ from where it developed, not where it ended up.
All right, section 6. We've talked about feeling the abdomen, understanding its wiring. Let's talk about looking inside without a knife. Radiographic anatomy.
The plain old abdominal X-ray. It gets a bit overlooked in the modern era of CT scans and MRI, but a simple X-ray can tell you a huge amount if you know how to read it.
It all comes down to the different densities of tissues, right?
4 basic shades. Gas is black because it doesn't stop the X-rays at all. Bone, or a calcium-containing stone, is bright white. Soft tissue and fluid are shades of gray. And fat is a slightly darker gray than muscle or fluid.
So where should we normally see gas?
You should almost always see a gas bubble in the stomach. You'll see variable amounts of gas mixed with stool in the large intestine, which gives it a kind of speckled appearance.
And the small intestine.
This is a critical point. In a healthy, mobile person, you should see very little, if any, gas in the small bowel. Things are moving through there too quickly. Seeing large, gas-filled loops of small bowel is a major red flag.
And if you see horizontal lines inside those loops?
Air fluid levels. This is when you take the X-ray with the patient standing up. If the bowel is blocked, fluid and gas back up behind the blockage. Gravity causes the heavier fluid to settle on the bottom and the lighter air to rise to the top, creating these perfectly straight horizontal lines.
They can look like steps on a ladder going up the abdomen.
That's the classic stepladder sign of a small bowel obstruction. It's a surgical emergency. It means there's a complete standstill.
What about fat? We tend to think of fat as just getting in the way on an image.
On an X-ray, fat is your friend. It provides natural contrast. The kidneys, for example, are surrounded by a nice layer of perineal fat. That fat is darker gray, so it creates an outline, allowing us to see the silhouette of the kidneys against the lighter gray of the surrounding muscles.
And that brings us full circle back to the psoas muscle.
The psoas shadow. On a good quality abdominal film, you should be able to see the faint diagonal line of the edge of the psoas muscle running down alongside the spine.
It's outlined by that retroperitoneal fat.
Precisely. And if you can see it clearly on one side, but it's blurred out or completely gone on the other,
that's a bad sign.
that is a very bad sign. It means something has infiltrated that fat plane and is obscuring the border of the muscle.
Like what, for example?
It could be pus from a ruptured retrocecal appendix. It could be blood from that leaking aortic aneurysm we talked about. It could be a tumor. A missing psoas shadow is a sign of retroperitoneal pathology.
You're diagnosing by seeing what isn't there.
It's a diagnosis by subtraction. It's subtle, but it's a powerful clue.
It's amazing how consistent that theme is throughout this whole discussion. The clues are almost always indirect. The rigid belly that isn't the appendix, the shoulder pain that isn't the shoulder, the missing muscle shadow on an x-ray.
That's the essence of clinical anatomy. It's not just knowing the parts, it's knowing how the parts talk to each other
Yeah.
and how they signal for help. It's learning to read the code.
Okay, let's bring this all together. Let's synthesize. We started this whole deep dive with that 15-year-old boy, doubled over in pain.
We did. And my hope is that now, when you picture him, you don't just see a label appendicitis. You see a whole dynamic process unfolding.
You can see the inflammation starting, stretching the visceral peritoneum and causing that vague central pain. Then you see it spreading, touching the parietal wall and creating that sharp, localized, somatic pain.
You can picture the reflex arc firing, causing the abdominal muscles to lock down and form a protective shield.
You can visualize the greater omentum, the abdominal policeman, migrating across the slippery intestines, trying to get to the scene of the crime and wall it off.
You understand why the nurses immediately sat him up in bed, to use gravity to drain any potential leakage down into the pelvic sump, away from the dangerous absorptive surfaces under the diaphragm.
And you can appreciate that if his embryonic rotation had gone differently, or if his appendix was tucked behind his cecum, his entire clinical picture could have been a complete and total mystery.
This is what some call the surgical sieve. You pour a patient's symptoms through a series of filters. Is it infectious, inflammatory, vascular, traumatic? But the finest, most important sieve is anatomy. Gravity, pressure, embryology, nerve pathways. These are the fundamental rules that dictate how and where disease shows itself.
It's not a static map in a book. It's a living, breathing, three-dimensional landscape with its own weather patterns.
That's a great way to put it.
We've tried to give you the guided audio tour, but like we said at the very beginning, Snell's Clinical Anatomy has the detailed maps.
Please, if this was interesting to you, find a copy of the book. Open it to the chapter Abdomen Part 2. Don't just read the words. Stare at the diagrams. Specifically, look for the cross-sections of the peritoneal reflections, figures 7.6 and 7.7 in most editions.
Because it's one thing for us to talk about the balloon and the fist analogy, it is a completely different level of understanding to see a cross-section diagram and trace with your finger how the visceral layer reflects off an organ and becomes the parietal layer on the wall.
That's the final step. Taking that 2D map and building the 3D model in your head. Because trust me, when you are standing in a hospital room at 3 in the morning with a sick patient, having that model isn't an academic exercise. It's the difference between seeing a confusing puzzle and seeing a clear diagnosis. It's the difference between confidence and panic.
Thanks for diving deep with us.
A pleasure, as always.
Stay curious.